Hey everyone, what's up? This is Dr. Charlie Johnson. Hope you are doing well. Appreciate you checking out my channel and this content. And the purpose of this video and this presentation, which I'm really excited to share with you, I put a ton of time and effort to synthesizing everything there is to know about this topic into a presentation for you, is we're going to talk about how specialists like myself diagnose and or figure out if the SI joint is the likely source of your symptoms, and how you can too. So much of this research and so much of what we know about figuring out if the cause of your pain is due to an SI joint problem lives in the brains of specialists, people like myself, right? And rarely do you get to really kind of see inside the minds of a specialist. And then very rarely does a specialist kind of boil everything down and synthesize things in a way that makes sense to you. So I get people every day who reach out to me and say, hey, Dr. Charlie, like, how can I tell if I have an SI joint problem? How do I evaluate to see if the SI joint is the likely source of my pain? Then beyond that, what do I do about it, right? And so the intent of this video is to be a really in-depth dive into how you can figure out whether or not the SI joint is the cause of your pain, and basically give you everything you need to figure this out, even from the comfort of your own home. So let's dive into it, okay? So how specialists diagnose SI joint pain and how you can too. All right, so here's what you're going to learn in this presentation. By the way, buckle up. This is going to be really in-depth, and be sure to stick around till the end because we're going to share all kinds of cool things for you, flowchart wise and whatnot. You're going to learn the difference between SI joint pain and SI joint dysfunction, and why one cannot be identified and probably will never be able to be identified. All about SI joint diagnostics. And again, we're going to boil this down in a way that makes sense to you, the person in pain. And specifically to help you do this, we're going to talk about how experts determine if your SI joint is the most probable. I underline that. There's a nugget there to be had. We'll talk about that in a moment. But the most probable cause of your pain with 78% accuracy, no injection needed. So lots of times we recommended to get an SI joint injection to figure out if that's the likely source of your symptoms. And with what you're going to see today, you really don't need that, all right? The three elements of a sound clinical diagnosis, and most docs miss at least one, if not more of them. The DIY diagnostic algorithm allows you to pinpoint SI joint pain better than most orthopedic specialists. So I promised you as you go through this, and after going through this, you're going to know more about how to figure out if SI joint is the cause of your pain than pretty much anybody else, all right? Doctors, specialists, they just don't really know this stuff. It's out there, but it takes upkeep. It takes continually, innovating and keeping up with the research. And I'm going to keep you up to date on all of that and make you your own little expert. All right. And I will share with you a flowchart, by the way, that's going to boil everything down, so you have no questions about what you need to do and kind of what you need to be looking for to figure out if the SI joint is the most likely source of your symptoms. Okay. What you need to know as far as the SI joint research I just mentioned that you should be aware of, and then how your diagnosis informs your treatment, and of course, some recommendations for relief. All right, so let's get into it. Pain versus dysfunction. So SI joint pain equals and or is defined as pain arising from the sacroiliac joint, SI, sacroiliac joint. And a joint is just a junction, if you will, between two bones. So you can see here in the red there's two SI joints. You have the ilium, or sort of that wing. It almost looks like the butterfly wing, right? That's called an ilium. That's one side of the pelvis. Then you have that triangular thing in the middle called the sacrum. And then you have another ilium on the other side. And, in the back, you have the connection between the two, one SI joint on the right, one SI joint on the left, kind of completes that pelvic ring. Now you have SI joint dysfunction. Maybe you've heard of this as well, which is essentially defined as impaired function of the SI joint, or the sacroiliac joint, whatever that means. We'll talk about that here in a second. So SI joint pain and SI joint dysfunction, if you have pain in what you believe to be the SI joint region, I just need you to understand they are not the same thing, all right? So the gold standard for diagnosing SI joint pain is a guided intra-articular, intra meaning within, articular, the joint, injection, or it's also referred to as a diagnostic block. So they inject lidocaine or some numbing agent with maybe a steroid, right, to determine, hey, is that the most likely source of your symptoms? And they do this under imaging. So it's guided. The needle is guided into the joint. But the gold standard for determining what is normal or abnormal position or function of the SI joint, it just does not exist. Right. And so we've done some different studies. This is going back to the 1990s. There's even studies way before this, and there's studies that continue to show the same thing over and over again. That feeling for the position of the SI joint and testing for its function is not a valid or reliable way. So if I assess what's going on with the SI joint based off of what I'm feeling, and then if 100 other experts do the same, we're just not going to agree. And so it's not a valid or reliable way of assessing the SI joint, and it does not even correlate to pain. So just because somebody has some asymmetry in the pelvis doesn't mean that's why they hurt or that they're going to hurt at all. All right. And so therefore, as a result of this, these so-called upslips, downslips, torsions, rotations, nutations, counternutations of the pelvis, right, and SI joint dysfunctions are just invalid because they lack a standard normative reference. None of us can agree upon what the heck we're even feeling, right, let alone that it has to correlate to pain, and that if there is an asymmetry, it's going to mean something. And so without black, you can't have white. Without normal, you cannot have abnormal. Without symmetrical, you cannot have asymmetrical. I think you see what I'm getting at here. This is the law of polarity. Nothing exists without context, right? So just as a compass requires a clearly defined point of reference or north to establish all of its other bearings and provide you with the other directions, without a standard of reference for what is normal function, the pelvis and SI joint, or position, one cannot determine that which is abnormal. You just can't do it. And this does not mean that problems may not exist. And I can hear the comments now, right? So are you saying these things are made up and everybody else is wrong? Well, sort of, but sort of not. Look, this does not mean that these problems may not exist or these abnormalities or asymmetries might not be present, but rather that they cannot be agreed upon or defined. So why argue about them? And why follow treatments in suit of them? So look, if you've been told that your SI joint or your pelvis or your one leg is longer than the other, or something shifted or rotated, upslip, downslip, anterior rotation, posterior rotation, it's twisted, right? You've got nutation, counternutation, an outflare, inflare. You're getting these types of assessments. What you can do, not based off just my experience, but based off of the science too, you can just lay these things to rest. So take the weight off your shoulder. You're not going crazy. And there's a reason nobody can agree upon what's going on and why you're told by one person the pelvis is this way and the other person the pelvis is that way, because there is no standard reference. It's not a valid and a reliable way to assess what the heck is going on. So you can lay these SI joint dysfunctions to peace. All right. Now let's talk about SI joint diagnostics. It's probably why you're here. You're wondering, is the SI joint the cause of your pain? And so we're going to do a really in-depth dive here and share with you everything I know and everything we know and everything the science says about doing this. All right. So as you'll learn in a moment, diagnostics are not 100% black and white, but rather exists in probability. So if you're looking for somebody to say, hey, with 100% certainty, this is the problem, a lot of times that's what people are looking for. Tell me what it is. Is it this or is it that? And if somebody can't be 100% certain, well, then, people want more certainty as to the cause of their pain. But just realize that diagnostics exists in probability. So we're looking for the most likely source of your symptoms. All right. And the main issue, or my beef, if you will, with diagnostics is that they don't tell you why the pain started in the first place, right? It tells you the most likely source of symptoms, but not necessarily what to do about it, why it began, or how to prevent it in the future. So just keep that in mind, all right? Take it with a grain of salt. And that is why I say, hey, look, you're going to watch this video, and this video is pretty much as good as it gets, people. So don't waste too much time beyond this video and going through these different tests. And be careful not to invest too much more, time and money into searching for a perfect 100% crystal clear cut diagnosis. All right. So diagnostics rarely inform treatment, again, unless you're seeking injections or surgery. So even if you do have SI joint, the next natural question becomes is, well, what do you do about it? Right. All right. So how do we determine if your SI joint is the most likely source of your pain? So we're going to walk through this. I'm going to walk through exactly how I would do it and what the research suggests and what my experience suggests. We're going to connect all the dots for you. Out of all the junk out there, this is all you're going to need. Okay, that is my promise to you. My promise is that you will know more than your local orthopedic surgeon, right, with almost 100% certainty about how to figure out if SI joint is the cause of your pain. And then I'm going to translate it to you in a way that makes sense such that you can start to do some of these tests at home. All right, so stick around for that. So this is really important to understand. The probability of a disease process or an SI joint problem, let's just say, is equal to its prevalence. Meaning, if you just called me up right now and you said, Dr. Charlie, I have some back pain, butt pain, leg pain, whatever. Well, there's automatically, without asking you any other questions, a certain prevalence, if you will, of conditions. Right? So we know, and you'll see here in a moment, that discs are, make up or account for a certain number of back problems, and then joint problems, and then SI joint problems, and nerve problems, and mind problems, right? And so we're going to share some of these things here in a moment, but just recognize that right off the bat, there's what we call a pre-test probability. Without knowing anything else, if you walk into the clinic and you have some type of back, butt, leg pain, right? There's already, without knowing anything else, X probability you have this, this, or that, all right? So this is an older study, but I like to refer to it because it is sort of a diagnostic study and a prevalence study. And basically people with just recurrent and persistent back pain continue to undergo diagnostic procedures until their pain was identified. The source of their pain was identified. And here's what it showed as it relates to the prevalence of different conditions causing back pain, the pre-test probability. What they found is that, let's just say you have 100 people who have some sort of back, butt, leg pain, all right? Roughly 41% of them, without knowing anything else, roughly 41% of folks are going to have pain due to the disc as the source of the issue. 31-ish% are going to have the facet, or the joints in the back, I'll show you a picture here in a moment, as the source of pain. 18% of people, again, you call me up, hey, I've got this problem, what's the chance I have an SI joint? Well, 18%, roughly. Well, you don't know anything about the condition. Yeah, but we know based off of different prevalent studies and different diagnostic studies that roughly 18-ish% of people, without knowing anything else, right off the bat, have an SI joint issue, all right? Probability that you'd have an SI joint problem of roughly 18%. And then say 10-ish% of these issues are due to nerve issues. We call them radicular syndromes and or radicular pain, pain due to nerve origin, all right? And look, I'm not saying that there aren't other sources of pain. There absolutely are. And in fact, I think these probabilities maybe are a little bit skewed and a little bit off, but I just want to use it as a benchmark so you can see sort of how diagnostics work, and then you can apply it to your own situation, okay? Now, look, the other thing too is a lot of times I get comments of like, well, could it be this and could it be that? Well, it could, but the prevalence of these cases with greater than one source of pain is just unknown. We don't have a whole lot of studies to say like, hey, this percentage of people have both a disc and SI joint, or a facet and SI joint, or an SI joint and a nerve problem. All right, so just know we're trying to isolate things, just one source of pain in these studies. This is the facet joint in case you weren't aware. It's also called a Z joint or a zygoapophyseal joint. All right, there are joints. Again, a joint is a bone-to-bone sort of junction on either side of the spine at each level in the spine. All right, I also highlighted disc there, and then that little red cord, I guess, is supposed to represent the spinal cord. So that's what we mean when we say facet joint. These are the three elements of a sound clinical diagnosis, all right? First things first, your story. What makes it feel better? What makes it feel worse? How long ago did it start? What started it to begin with? All of these things. Location of symptoms, basically where do you experience your sensations? And finally, a movement or clinical exam, the different movements that make you feel better or worse or provoke the pain or reduce the pain. And what's really cool is that this is what makes up a sound clinical diagnosis. But these things, as you'll see in the research, have been compared to the gold standard sort of medical diagnosis, which is a guided anesthetic injection into the SI joint. And that is sort of the best or cleanest or gold standard diagnostic criterion for saying you have SI joint pain. Again, SI joints are considered positive, and the SI joint is considered to be the source of pain if you have at least an 80% reduction in your pain for as long as that anesthetic effect lasts. All right, so an expert diagnostician uses these elements and what I call negation logic or deductive reasoning to determine the most likely source of your symptoms. This is important to understand too, because everybody wants to know, well, what is the cause of my pain? But by knowing what isn't the cause of your pain, you can also kind of figure it out. Right? If you know that X, Y, and Z is not causing your pain, then it leaves only maybe this is the most likely or most probable source. And so this is the way diagnostics work. Again, they are based off of probabilities. There's very clearly 100% this or that, but it is valuable to start testing things and ruling things out to ultimately be able to rule in what something may be. And that's how we're going to do it. So first things first, your story. So what is a story consistent with people who have SI joint pain? Well, usually they're actually a little bit older. So people with joint problems tend to be a little bit older. Maybe it's due to irregularity in the surfaces, meaning like arthritic or degenerative changes. But that's just what we found. SI joint problems and joint problems in general, a little bit older, we'll say age greater than 50. But of folks who are, say, younger than 50, pregnancy would also be sort of a common demographic, if you will, and or scenario where we might see SI joint aches and pains occur. There is a hormone called relaxin secreted during pregnancy, which can create, for lack of a better word, less stability within the pelvis in preparation for childbirth, which can sometimes stress out these joints. and then previous spine surgery. So if you fuse the low back, which is meant to move, right, some other joints need to pick up the slack. You're not just going to stop moving in life. So a lot of times you'll see stress goes to the pelvis, and you'll see stress fractures of the SI joint and or aches or pains as that load or that movement is transitioned elsewhere in the body, usually to the SI joints. And then the descriptor of sensation. So if you're coming to me right away and you're saying, hey, I've got burning, numbness, and tingling, right, the chance you have an SI joint problem goes way down because most people do not describe SI joint pain as that of burning, numbness, or tingling, which is more quality associated usually with nerve type symptoms. That's the story. Now, location of symptoms, it's usually one-sided. Even though you have two SI joints, one on the left, one on the right, usually it's one-sided. It's usually dominant pain in the area of the buttock. You'll say, hey, I got pain kind of in the dimple area of my back, and it goes right into my buttock, and that's where I feel most of the symptoms. You have generally what we call a positive Fortin finger sign. I'll show you what that means in a moment, but basically pinpoint pain right over the SI joint. And SI joint pain, while it can go above or below, it rarely ever goes below the level of the knee and rarely ever above the belt line. It's just not a very common referred pain pattern. We call it a referred pain pattern. Okay? This is a decent drawing. You kind of see at the very top of the crack, you see a little down arrow, right? That's kind of like the coccyx, the bottom of that triangle, the bottom of the sacrum. And you go up and to the right, you can see sort of, if you've ever looked in the mirror, maybe see a little dimple on your back, right? Right on that dimple, we call it the posterior superior iliac spine. That is sort of the junction between that butterfly wing or that ilium. You can see the little crest there of the ilium or the hip bone. And then that's where it joins the sacrum, all right? And so that is where a lot of people, again, one-sided, usually feel or experience pain when they have an SI joint problem, all right where he's putting his finger. Again, let's talk about these pre-test probabilities. So remember in that study, I said, hey, a lot of people with back pain, and they kept getting diagnostics done until they identified with as high a probability as possible the source of their symptoms. Well, 41% of people presenting to a clinic with back, butt, or kind of leg pain are likely to have a disc problem. 31 facet, 18 SI joint, nerve, or radicular pain, 10%. And so I know we reviewed this, but just wanted to share this as we'll move into some things here in a second. What's really cool about knowing these probabilities at a baseline, you can see it right here. Again, you come in, chance you have a disc problem, 41%, facet, all kind of denoted by the graphs there. Hopefully you can see. SI joint 18, nerve 10. If you just tell me the location or symptoms, Dr. Charlie, I've got pain and it's right in my butt. Well, look what that does in my brain, right? In any good diagnostician's brain, and now in your brain, right? Look what it does to the probabilities, right? It shifts the SI joint much higher. So SI joint goes up, disc goes down, nerve goes down as well. So if you've got pain in the butt, right away, just by knowing that, SI joint probability goes up, disc goes down, nerve goes down as well. Now, let's just say you tell me something different. Dr. Charlie, I have pain centrally in my back. It kind of goes across my belt line. There's a lot of pain and stiffness there across my just entire lower back or in the center of my back. Well, right away, the probability you have disc as a likely source of your pain goes way up because we know that SI joint pain very rarely goes above the level of the belt line. Nerve usually goes below the level of the knee into the foot, causes pain, numbness, tingling, right? And facet joint problems are usually just one-sided. So you can see how the probability shifts just by knowing location. How cool is that, right? Now, let's just say you present with something like this. The pain in my back, it's one side, it goes in my butt and a little bit down my leg. A little tricky, right? Well, not necessarily. And you'll see how this all comes together later, but right away, we can say probably not SI joint, and you can see it disc and facet probability go up in proportion. Probably not SI, because again, SI rarely goes above the level of the belt line, and probably not nerve, because nerve usually goes below the level of the knee into the foot. All right, and we'll talk about how we can get even better or kind of zoom in on the most likely source of your symptoms using some other components of the clinical exam here in a little bit. All right, so location alone can tell us a lot about the most probable source of your symptoms. So we talked about the story, location of symptoms, and how that increases probability. But now the final piece is this movement and or clinical exam. And again, all of these things are compared to the gold standard, which is a diagnostic block and or injection into the SI joint for diagnosing SI joint issues. And so the clinical exam has a few components. And again, we're going to tie all of this together for you and make it really simple. So if you're feeling a little overwhelmed, I get it. We're going to lay it out inside of a flowchart. Okay. So first part of a clinical exam should be for what we call assessment of centralization or peripheralization. I'll explain that in a moment. Then the second component in no specific order, by the way, but the second component would be a neurological exam, right? And the third, probably last component would be what we call SI joint provocation tests. So we want to assess for what we call centralization or peripheralization. I'll explain that in a moment. Then we want to look at the health of the nervous system via neurological exam. And then we want to do what we call SI joint provocation tests. These are tests designed to irritate or aggravate the SI joint. So what do I mean by assessment for centralization or peripheralization? Maybe these are new terms to you, so I just want to make them super clear. So the centralization phenomenon is the progressive retreat of referred pain towards the spinal midline in response to repeated movement testing. Let's make this very clear, and I'm going to show you some examples. Centralization is basically, hey, I've got symptoms down in my calf, and when I do certain repeated movements or movements of my back, in this case, spine, it moves from my calf and it moves closer to the midline, maybe the back of the leg or closer to the back. So taking things further away from the spine and moving those symptoms closer to the spine. That is centralization. So centralization is a term basically coined by Robin McKenzie, the McKenzie method. Maybe you've tried it, maybe it's worked, maybe it hasn't worked. We call it mechanical diagnosis and therapy. You can become a diplomat in this training. I've gotten to work alongside several of them, really smart people, or you can become certified in this type of therapy, in this method, if you will. And the story is that, Robin McKenzie supposedly, this is what I've been told, kind of messed up, discovered this centralization and what you'll learn in a moment, peripheralization sort of concept by accident. He was laying there with somebody who had a disc problem or something going on and propped them up in extension, right? Propped them up so they were bending backwards. And that wasn't something we typically did in the olden days. A lot of times we had people bend forward to relieve symptoms. But in this case, had somebody sort of stuck in extension, left him there, came back, and they said, hey, I'm feeling way better. He was like, what the heck? And so he started to look into this. All right, kind of a neat story. And so a couple examples of what centralization is and what it isn't, right? Centralization, again, you're taking these symptoms, right? You're moving them closer to the spine. So let's just say you start with symptoms in the butt, and then you go through, we'll just say that green arrow represents you going through motion, right? Going through some repeated motions, as we'll show you in a minute. And now you don't have it in your butt, but you have it in your back. Oh man, my back's really achy now, Charlie. Well, that is centralization. It went from the butt to the center of the spine, right? It moved closer to the midline. Or maybe you start with symptoms in your butt and they go away. That is what we will also define as centralization. Your symptoms abolish, they go away. Or maybe you have symptoms all the way down your leg, through your calf, even into your foot. But you do some different motions and now my calf is better, but man, my hamstring's on fire and my back hurts. That is centralization. Now, peripheralization is the opposite. So symptoms start kind of centrally and then they go peripherally, all right? So let's just say you have some mid-back pain or stiffness, you're doing some different motions, and then, man, my back feels a little bit better, or maybe my back pain is still there, but now I've got it in the butt. It's moving away from the midline. Or, hey, I've got it in my back and in my butt and down my leg, and now after doing that stuff, Charlie, it's all the way my foot. It's called peripheralization. It's moving further into the periphery. Hopefully that is clear. Now, a quick example of that which is neither centralization or peripheralization, just so you see what I'm talking about. So maybe you start with pain in the butt. You're like, hey, I wonder what's going on here, right? You do a bunch of different motions, right? Repeated motions exam, again, as we'll show you here in a second. And maybe the symptoms get a little better, a little worse or whatever, but they don't move. You still have the same pain in the butt. Well, symptoms didn't move closer to the spine. They didn't move further away. They just are kind of stuck there. That is neither centralization or peripheralization. No centralization or peripheralization occurred in this example. Hopefully that's clear. If it's not, go back and rewatch so you get the definition of this, all right? It's important because we're going to use this to determine if an SI joint problem is the most likely source of your pain. So to be clear, if your symptoms are resolved while performing a repeated movement exam, they go away, or they move further up the leg, centralization, or further down the leg, peripheralization, this is a sign of the centralization peripheralization phenomenon and is most consistent, here's the key, is most consistent with disc pathology. Studies back in the day, in the early 2000s and even before, started to look at this idea of like, well, what does centralization mean? What they found is that centralization is highly specific or diagnostic of a disc problem. Right? So if you experience centralization, it probably tells you have a disc issue. If you don't, then maybe you don't. All right, pretty cool. Okay, so screening for the centralization and or peripheralization phenomenon is useful because many people with disc issues will have false positive SI joint provocation tests. And this is what so many experts get wrong. They do these SI joint tests and they're like, yep, you have an SI joint problem because those things hurt. Well, if you have an upstream problem in your back, it can cause the water downstream to become muddy. An upstream problem can cause a downstream effect. So if you have a disc problem, it can sensitize and irritate the SI area, as well as the hip, as well as the nerve, as well as everything below it. And so if you don't rule out the spine as the source of the problem, if you don't start upstream and rule that out, then you can do these tests I'm going to show you here in a minute. You're going to say, yep, they hurt. But in the presence of an upstream problem, a disc problem, for example, it is very possible you have a false positive, meaning it'll look as though the SI joint tests are positive, and they will seem very positive. They'll provoke your familiar pain. But it's the disc or upstream problem that's causing that area to be sensitized. And so it's not an SI joint issue. It's just that you're getting a false positive or just a faulty read, if you will, on the tests. All right. So how do we assess for this? All right. We go through what we call a repeated movement exam. This is going to get a little deep. There's a little bit of interpretation here that could occur, right? But I'm going to do the best I can to make it as simple and straightforward as possible. So again, Rob and McKenzie method brings people through a repeated movement exam. All right. And so you can see this is actually taken from that centralization article. And they went through these different tests. And this is what, say I would go through and or could go through, or other people, right, who are going through this diagnostic algorithm to determine the most likely source of your symptoms. These are motions we could go through. So you can only move your spine in so many directions: north, east, south, and west. All right, pretty much. All right. And then you can twist it a little bit. So, we can move your body forward as an A. You can see we can move the body into flexion. That's forward. We can move the body B into a backwards motion. We can tilt it right, tilt it left in standing. And then we can do the same things in a lying position. So the top pictures are kind of in a loaded standing position, and the bottom pictures are in a lying position. And the reason we do that is that sometimes you can have a different response based off if you're on your feet or you're not on your feet. All right. Now, for the sake of keeping this pretty straightforward, we're going to actually avoid and or drop out some of these side bending maneuvers and then these twisty maneuvers. And the reason being is that forward bending and backward bending are very revealing. Most people, if they're going to have centralization or peripheralization, will experience that doing these just forward and or just backward motions in either standing or lying. So these are kind of high yield tests. All right. So that's what we're going to do. And you can do it along with me. Again, you can stop this, you can go back, just get the concept for now. All right. What you see here is taken from, all right, the form. You can download this for free. This isn't copyright or anything like that. But this is the lumbar spine McKenzie exam form. All right. And you can see here, REPFIS. What the heck does that mean? That means repeated flexion and standing. And somebody like myself could go through this and determine, hey, how's the person moving and what happens to their pain as they do these different motions, right? And it helps us kind of keep score, keep tally on your response to a repeated motion exam. So repeated FIS is repeated flexion and standing. Repeated EIS is extension and standing, a back bend, right? Repeated FIL is flexion and lying, a knee to chest. Repeated EIL is basically a press up, right, or a cobra motion. Quick reminder, because we are going to have you go through this. There's a very low probability. It doesn't mean you can't go through this. It just means right off the bat, based off your location, there's a low probability of you having an SI joint problem if you have symptoms that look like this. Right? If you have symptoms go all the way down the leg, probably not. If you have central low back pain, well, SI joint doesn't really occur or refer above the level of spine. And, if you've got one-sided, again, symptoms above the spine that also go into the butt and down the leg, probably not. All right, could be, but low probability. There is a higher probability right away. We talk about shifting of that pre-test probability or likelihood of what's going on. This is going to shift it higher, all right, towards that of potentially an SI joint pain and or issue, okay? Quick disclaimer too, the validity of any clinical exam procedure and or testing is only good as your ability to tolerate it. All right. So sometimes people come in to me and they're like, hey, Charlie, what's going on? And I'm in so much pain. And I'm like, well, unfortunately, like trying to go down this diagnostic testing route and or rabbit hole of doing all these different motions is just going to flare you up. And so that is part of the clinical reasoning. And so I would ask you to use your own judgment, your own best judgment and your own reasoning to determine like, hey, are you going to be able to tolerate going through these different movements? If the answer is no, and it's going to flare you up, then it's not worth it. Don't do it. Come back at a later date and or reach out directly to me or something like that. But again, the information gleaned from a clinical exam is only as good as your ability to go through it. So I found that about 60% of people can actually go through an exam process like this because it involves actually provoking your pain, also reducing it maybe, but a lot of times provoking it. And, if everything's sensitive, then the waters are going to be very muddy and it's not going to give you clear data. If you don't have clear data, you can't give a clear diagnosis and or reason for or explanation of why someone hurts. Hopefully that is fair. Okay. Here's how to perform the repeated movement exam and assess for centralization or peripheralization. Hang in there with me. First thing you're going to do, this is the first motion we're going to do. What I would recommend is that you do one rep, one time of what we call flexion and standing. Just try it one time, okay? Now, before you even do it though, get a baseline of where your symptoms are. So you kind of remember that pain drawing. Get an idea of what you feel. If you feel nothing, that's okay. If you feel something, just kind of map it out in your head and maybe rate it. 0 is nothing, 100 is like the worst ever. I like to use the 0 to 100 scale, it kind of blows it up. 0 is nothing, 100 is the worst pain ever. Is it low? 10, 20, 30. Is it medium? 40, 50, 60. Is it high? 70, 80, 90. Again, if it's high, 70, 80, 90, the chance you're going to be able to go through a bunch of these tests is not good. But if it's low to moderate, you can probably get a clearer read. Okay. So after you have an idea of where things are symptom-wise and what you're experiencing, right? Location-wise and how bad things are or how good things are, right? The extent to which you feel symptoms, then go ahead and try one repetition and get an idea of what you feel. The intent of this is really just to kind of, better understand how you're moving and then also just make sure that it's something you can tolerate because as part of this exam, it's called a repeated movement exam. So then what you would do after one rep is you would go through and you do say 10-ish or so reps of it. So you go all the way down as far as you can tolerate, back on up. All the way down as far as you can tolerate, back on up. And you would do 10 of these. And then after you're done and while you're doing it, right, you would be kind of keeping tabs on what's happening to your symptoms. So again, we're assessing and we're doing this to determine if you have the presence of centralization or peripheralization, all right? So you had a certain location of your symptoms. You felt your pain in a certain area, right? And to a certain extent. Now, after you've done 10 of these, what happened to it? Did it change locations or not? If so, did it move closer to your spine, higher up, or did it shift? And did it go away and then did it go lower in your, say, leg in this case, right? If it moved, in either case, we call that either centralization, it's going closer to the spine, or peripheralization. If it didn't move, right, and it's still in the same spot, right, then no centralization occurred, no peripheralization occurred with that motion, all right? So we can kind of check that off. Now, you're going to do extension in standing. Again, I would do one rep or so just to make sure it's tolerable and get an idea of, okay, what do you feel when you do it? And again, you're going to kind of record a baseline. You feel symptoms of the calf and the hamstring, just in the butt, just in the back. Where do you feel it and how bad or how yucky is it? Low, medium, high. Take a snapshot of that. Great. As long as you can tolerate the one rep, let's do 10 of them. Hands on your hips just like that. Go back as far as you can. You can stagger your stance a little bit if you want to, as far as just maintaining your balance. But this is the idea. Go back as far as you possibly can, not losing balance or anything like that. Then again, you're just taking note as you're doing it. What's happening to your symptoms? Was your pain in your butt and now it's in your calf? If so, it moved, right? So did your symptoms move? It's the first question you want to ask yourself. If so, then there is some type of centralization or peripheralization, all right? Did it move closer? Did they go from the did it go from the calf to the back of the hamstring or to the butt? Centralization. Did it start in the butt and now after doing 10, now it's in the calf? That's peripheralization, right? Shooting down the leg, that's peripheralization. Did it move? And then where did it move, right? Did it centralize or peripheralize? All right, let's just say that it didn't move at all. Keep going, right? Now we're going to go to an unloaded movement. So we did the 2 movements standing. Now we're going to go forward and backwards while lying. Right? And so again, I would do one repetition of the flexion line, which is really just a fancy way of saying double knee chest. Pull them tight to your chest. All right. So you get to the end of the motion to fully explore that range of motion. Get an idea of what you feel. Again, just in baseline, maybe just laying there. Where are symptoms located? Pay attention to the location, because that's how we determine if things move or not. And then how yucky? Low, medium, high. Take a snapshot of that. Do one rep. What do I got? Great. As long as you can tolerate, do 10 of them or so. Did symptoms move? They move closer to the spine, centralize, or peripheralize. And by the way, at any point, if you notice the symptoms clearly move, they centralize or peripheralize, you can be done because you've assessed for centralization or peripheralization. You've experienced it. You don't need to test any more than necessary. All right. Let's just say symptoms didn't move. You're still testing. Right? Now you lay on your belly. Maybe get an idea of just baseline, how you feel flat on your belly. Right? Location of symptoms. Severity of symptoms, low, medium, high. Do one rep just to see what your motion is and if you can tolerate, and if you can, do a bunch. Maybe as you do it, you notice that, man, I'm getting further and you know what? Symptoms were in my butt, but now they're just in my back. My butt pain went away. That's centralization. Maybe the more you do it, the more you realize that, wow, symptoms are shooting down my leg. I actually think my calf is tingling a little bit. My foot's going numb. That is peripheralization. Either way, that phenomenon is present. And again, you could stop because you've experienced centralization and or peripheralization. But maybe nothing happened. Maybe symptoms didn't move. You went through all these tests and maybe got a little better, a little worse, right? But it's still yucky, just in the same place. All right, so while performing any of these repeated motions, did your symptoms move location, centralized or peripheralized, or did you find a movement that resolved your pain in totality? Did it make it go away? So maybe you had pain in your butt, but as you were doing a bunch of those little push-up things, your pain went away. That is still what we would call centralization. Your pain abolished. Moving the spine changed your symptoms. Pretty cool. Probably points to a spine problem, and specifically, probably a disc issue. We'll cover that in a second, right? If your pain did not resolve, or the location or symptoms did not change, stayed painful in the same spot, then no centralization or peripheralization occurred. Hopefully that is clear. Again, you can go through this, slow me down, and review it if you need to. All right. So this is the important part. The absence of centralization or peripheralization, your symptoms didn't move, all right, helps exclude or rule out disc as the most likely source of your pain. How cool is that? So now by knowing what something isn't, we can start to kind of increase the probability that other things are. So we assess for centralization or peripheralization, try to rule in and or rule out disc issues. Now we can look at the health of the nervous system via a neurological exam. So a neurological exam has several components. Again, you won't be able to do all of these from the comfort of your home, but I will at the end make sure that it makes sense to you and put this in a package, if you will, that you can apply to your situation. And you do not need, say, a reflex hammer, or you do not need years of testing to figure this out. All right. Neurological exam. So nerves carry information such as feeling and movement, sensation, strength, all of that. All right. We can test the sensitivity of the nervous system by stretching on it certain ways. And we can also test, again, the strength and feeling and all of that, or the health of the nerves in the back and down the leg. So first things first, strength. The most commonly affected nerves in the spine are going to be the fifth nerve, L5, and then the first nerve in the sacral area, S1. So to test these, we can do some different strength tests. Really simple. The first one, which we call like calf raises, I guess, going up on your toes. Do this on the good leg. I would do these individually, not like she has or he has. Go up on the right leg only, do a bunch of calf raises, and then do it on the bad leg or the affected leg. And if there's a problem with the S1 nerve root, S1 nerve controls kind of your calf muscles, then you'll lose power to these muscles. You'll notice, man, I cannot go up on my calf. I can go up on one side, but not on my other side. Try walking on your heels. The muscles that allow you to walk on your heels, the shin muscles, as well as the muscles that go to the big toe, a little harder to test on your own. But those muscles are supplied by the fifth nerve in the spine. So try walking on your heels. And if you notice that your foot is slapping on the one side, and again, that shows an issue with strength. And that's what you're looking for. Is there any impaired strength, right versus left? Sensation, as you can see here, right? Kind of highlighted. It's a little bit small, but you can kind of see the red highlight. So there are things called dermatomes, basically pieces of real estate and or areas of the leg, right, that are supplied by these nerve levels. So the fifth nerve in the spine, you can see kind of starts in the back, then it goes the outside of the knee to the shin, right? And then to the top of the foot. That's the L5 area, right? The S1 area is kind of, again, down the back of the leg, the back side, almost like the calf, the back of the calf, and then the outer ankle bone and the outer two little pinky toe, all right? Two smaller toes on the outside of the foot. All right, if you have an issue, something is maybe pinching or irritating or compressing or whatever the nerve up in the spine, right, and it's a problem with the L5 nerve, then what you can do is you can just test the feeling of your leg. Maybe you close your eyes, you take a little cotton ball or have somebody test this for you and say, hey, run that cotton ball, right, or run your finger very gently over that L5 area. You see where that mapping is, right, kind of the front of the shin and top of the foot. Is there a difference right to left? Then do it, right, on the outer side of the foot, the pinky toe side of the foot. Very, what we call light touch. Is there a difference right to left, right? And that tests and or assesses sensation. Tests for the function of the nerve as it relates to the sensory fibers. And look, we're not talking that you have some pain or tingling or feels like water's trickling down your leg. Those are weird sensations. We're talking like actual loss of sensation, objective loss of sensation. All right. I can't feel when you touch that, or that one feels definitely and clearly different, right versus left, or vice versa. All right. That's how you test for sensation. Reflexes, there's three main reflexes they test for in a neurological exam. They're going to bang your knee. Probably remember that one. Your knee goes, whoo, right? Right versus left. That tests the L4 nerve in the spine. They're going to tap your Achilles. So you can do this many different ways, but they hit your Achilles, and you'll see your foot will kind of do this. All right. That tests the S1 nerve, or the first sacral nerve in the spine. And then there's a little tendon behind your inner ankle bone they can hit, and your foot will kind of flick in. That assesses for the fifth nerve in the low back. Okay, so they can test for that, or specialists can test for that. Again, really difficult for you to do. You can try it, I guess, if you want, but I would probably say exclude that if we're going to do a self-test. And again, I'll make sure this is very clear at the end of the day. All right. And then finally, nerve tension test. So remember, nerves carry information such as feeling and movement, but we can also test to see if the nerve is sensitive. The wire is hot, if you will. If a nerve is irritated, when you pull on it, it's going to say, ouch. Right? And a simple test you can do, which is highly sensitive for and or really good screening test to rule out whether or not you have a nerve problem, is what we call a straight leg raise test. If you take your good leg, do this test, then take your painful leg and do this test, right? And if you're able to do this test, and this test is negative, it's completely normal, then the chance you have some type of nerve irritation and or sciatica is like really, really low. All right. So you could be, 90 to 95% confident that you do not have a sciatic nerve issue if you can perform this test normally. Right? So that is a complete neurological exam. That is the second component of the clinical diagnosis. And a normal neurological exam helps exclude nerve problem or radicular issues as the source of symptoms. So you can see how we're actually ruling things out to eventually rule something in here. Pretty cool. The final piece of a really solid clinical exam is what we call SI joint provocation tests. SI joint provocation tests are meant to do exactly that, provoke your familiar pain in or about the SI joint area. A while back in the early 2000s, a guy named Mark Laslett, one of my mentors, teamed up with Charles April out of Louisiana, and Charles April was a surgeon, and they were able to kind of do this clinical exam, these SI joint tests, and then the surgeon was able to kind of give some diagnostics, right, to say, hey, what is the utility and or the validity of these tests to determine if somebody, compared to that injection, right, actually has SI joint problems. All right, pretty neat stuff. So they started to come up with a cluster of tests that could predict whether or not somebody had SI joint issues. So these are it. All right, and you see there's 5 of them here, and each of these is designed to stress the SI joint in different ways. All right, so for example, you can see in the first one, figure 1A, distraction test, we call this. So you kind of take those bony bumps in the front of your hip and you would have somebody push on them. Now, I'm not recommending you do this at home, but just understand that if you were to go see a specialist and they were to go through a really thorough exam to tell what the heck was going on, these are the things that they would be doing, all right? And so this kind of gaps, if you can imagine the pelvic ring, if somebody's pushing on my hip bones, it kind of gaps the front of the SI joint, stresses it that way. The thigh thrust test, all right, is where you're stabilizing. His hand is going under and kind of on that triangle, right? And then he's pushing down through the axis of that leg bone, the femur, to try to shear it. Right? Then you have this Ganslin's test, where you can see you're kind of trying to like rotate and or again shear the SI joint issue in some way. This compression test, you're laying on your side and you provide force through the outer side of those kind of wing bones or ilium, those hip bones. And again, if you're doing that, then you're stressing or gapping probably the backside of the SI joint, all right? And then you're just thrusting directly at it, all right, to create some irritation there. So we call this a sacral thrust test, all right? And again, I realize that you can't do these at home, nor would I recommend that you try to do them because you need to have sufficient force applied and things like that. So the little experience there is valuable. But again, there is a way that we may be able to replace some of these things, and you can do it on your own. I'll share that with you shortly, all right? So what we found, though, is that 3 or more of these SI joint provocation tests, which provoke the SI joint pain or the patient's familiar pain, significantly increases the probability of SI joint as the pain source. All right. Now, you could just do those tests, and it, points with a decent likelihood that it could be an SI joint problem. But you want to look at everything that we just talked about together. When you package everything together, you can have a really high certainty the SI joint is the most likely source of your symptoms, okay? So if you put together the absence of centralization or peripheralization, essentially rules out disc, right? A normal neurological exam rules out nerve, and 3 or more positive SI joint tests, and you can be clustered together highly certain with a 70 to 80%, 78 is what the research suggests, percent probability you have an SI joint issue. How cool is that? And the utility of this is that you can be 78% sure that an SI joint issue is the source of your pain or your symptoms with a clinical exam alone, without needing to go get diagnostics or an SI joint injection, because this clinical exam was compared to and predictive of people who would respond to an SI joint injection. So the studies have already been done. You just don't know about it. This is it. Clinical exam. This is what we've gone through so far. Let's tie everything together for you, because I imagine your head's like swimming with all this information. You're like, shoot, I got to go back and watch all of this. We're going to try to make it really simple for you. Okay. So assessment for centralization or peripheralization is the first part of the clinical exam using a repeated movement exam. All right. We assess for the status and or health of the nervous system via neurological exam, strength, sensation, reflexes, nerve tension tests, at straight leg raise, etc. Then SI joint provocation test, all right, the distraction, the thigh thrust, Ganslins, compression, sacral thrust. These are all the tests that somebody like myself, if you were to meet in person, could go through or would go through to start to kind of change the probability and really zoom in or hone in on the source of symptoms, all right? Now, the problem is that you can't do reflexes, right? Or you could, but it'd be a little awkward. And chance that you're going to be able to do any of these things, or somebody you know is going to be able to do any of these things and have any idea what the heck they're looking for, is not high, these provocation tests. So it's like, well, what do you do, right? And we're going to share with you what to do, how to make this clinical exam something that you can assess and do on your own. Real quick, before we do that, this is the power of all of this. If you understand it, this is how probabilities change, all right? So again, without knowing anything else, you have a back butt sciatica problem, 41% probability you have a disc issue, 31 facet, 18 SI joint, nerve, maybe 10, all right? Again, I'd maybe change these a little bit and maybe add some other things in, but let's start with this. You'll get the idea. Again, let's go back to, these are the baseline probabilities. Okay, you tell me right off the bat, hey, I've got pain just in my butt cheek, right? As you can see, SI joint probability, we reviewed this earlier, goes up and nerve goes down a little bit. Now, if I go through the clinical exam and you do not centralize or peripheralize, which essentially excludes disc, so notice how it drops the disc probability by about 50%, because roughly half of people with disc problems will centralize or peripheralize. All right, so location, boom, SI joint goes up. No centralization or peripheralization, bam, disc goes down, the others go up in proportion. And then normal neurological exam, nerve, not nerve, 3+ or 3 or more SI joint tests are provocative of your pain, boom, 78% chance you have an SI joint problem. How cool is that? You didn't need an SI joint injection, all that pain, all that suffering, all that money. You're on YouTube and you figured it out, right? All right, so let's keep going. Okay, so now baseline probabilities, 41, 31, 18, 10. You tell me I've got pain in the center of my low back. Disc goes way up. Now, you go through that repeated movements exam and you notice, bam, that pain goes away and motion improves, or centralization occurs when you repeatedly bend backwards. I mean, do we need to do any other tests, people? There's a, 80, 85% chance that your problem is disc. And we're not going for 100% with diagnostics. We're going for as good as we can get. It's a very high probability and everything else goes down. We don't need to do anything else because we know that centralization is predictive of a disc problem. It is specific and or diagnostic of disc issues. Pretty cool. Final example. You come in, you say, hey, I've got pain here. Automatically, SI joint is going to drop and nerve is going to drop. SI joint drop again because it rarely goes above the low belt line, and nerve is usually below the level of the knee into the foot. So boom, disc or facet. How do we tell? Well, it's one-sided, so it could be facet. It could also be disc, right? There's a normal neurological exam. Because of that, nerve goes down. It's pretty low to begin with, but nerve goes down even more. There's only one SI joint test that's positive. Remember, we're looking for 3 or more. SI joint essentially is gone. Now it's like, all right, which is it? It's a toss-up. Is it disc or is it facet? Could be either. No centralization or peripheralization occurs. Just stays one-sided and you can't get it to move with repeated movement testing. Facet. Joint in your spine on one side. That's it. Pretty cool, isn't it? All right. So you might be saying, well, what can I do at home to determine with the highest probability that the SI joint is source of my pain? You went through all this fancy stuff, Charlie, but I can't do some of the stuff you were showing. And so how do I figure this out? Here's how you do it. All right. So remember, you saw this. You can't do some of these things. Reflexes, maybe you're not sure what you're looking for. Provocation test, boom. could we replace those? Could we replace those provocation tests, which are kind of awkward and clumsy? You got to have somebody else to do them and pushing on weird areas, right? With something that could maybe help identify if you have some type of pain in the SI joint. And turns out maybe we can. Maybe we can. I think it's good enough. All right. So back in the early 2000s, all right, and now as of recent 2021, there are some tests and or studies that have been floating around which looked at screening for pelvic girdle pain. Now, this isn't SI joint specific. This is a limitation of these studies. This could be a problem in the SI joint, could be a problem somewhere else in the butt, could be even some back stuff that's referring there. They don't really try to kind of differentiate between the two. But there are some self-administered tests. That's what I love about it, kind of DIY tests that you can do to screen with all the other things. Remember, we're going to cluster all this together to determine, do you have SI joint issue or a very high probability of having it. The other limitation is that this was done in pregnant women. Right? It was also compared to non-pregnant women, but pregnancy-related stuff. All right. So take it with a grain of salt, but I think, again, there's still utility here. All right. And then they validated these self-administered or self kind of DIY tests for screening for this pelvic girdle pain, again, 2021. And what they found is, forget about those arrows over there, what they found is that one test they had people do to determine if they had posterior pelvic girdle pain was this test. Well, what does that look like? That looks very much like a thigh thrust, if you ask me. All right. And that's probably why they created it. They probably said, hey, we want to take, just like Charlie's trying to do, Mark Laslit's test, this expert, this diagnostic PT, physio, and expert, right, in the SI joint sort of world. And he did a test like this. I wonder if you actually need somebody else to do it, or could you do it yourself? So you flex your hip to 90 and you push downwards through the axis of the femur. Again, it's a provocation test. It should provoke your familiar pain. And then they did this single leg bridge test. So these were the two tests that they looked for, and they assessed validity or as it relates to determining SI joint issues. All right. And this kind of looks like this test, doesn't it? Right. So he's pushing one leg down, the other one's kind of pulling up. In this case, you're just actively pushing one leg into the ground, and then your hip flexors are pulling the other leg up towards the chest. Huh. Pretty cool. Same kind of push-pull mechanism. And so this kind of looks like, they call it a single leg bridge test or a bridge test, but this could maybe be a liken to the downslips test, specialist clinical exam, right? But again, let's get rid of reflexes and let's replace all these SI joint tests with just these two. The self thigh thrust test, I forget what they call it, but P4 test or something like that. And then this single leg bridge test. And so then your at home or self SI joint clinical assessment becomes a cluster of things. You have to have location of pain consistent with SI joint pathology. You have to assess for centralization or peripheralization. You have to do that via repeated movement exam. You have to screen the neurological system to make sure that it's healthy and essentially rule that out. You can go through strength. You can do some sensation testing, and forget about reflexes for a moment. You can go through a simple straight leg raise, a nerve tension test. And then you can go through these SI joint provocation tests, not all the fancy ones that maybe I would do or something like that, but why not try these, little thigh thrusts and a single leg bridge? So what does this look like? Well, here is the algorithm. This pulls it all together for you. I'm going to step you layer by layer through a flow chart to help you connect all the dots in a very visual fashion if you're a visual learner like I am. So let's dive into it. All right, so you are here because you have some type of back, butt, and or leg pain, and you're trying to figure out if the SI joint is causing it, or maybe you're just not sure, all right? So here's a really nice algorithmic way and a visual way to walk through and figure that out, all right? So do you have pain in your back? This is a yes or no answer, all right? If you only have pain in your back here, all right? Pain above the level of the belt line, we'll define it as, and kind of pain right below the rib cage, spanning somewhere right to left there, right? Then if yes, SI joint is not the likely source of your pain. We talked about how the location of your symptoms can predict sort of the source, not with 100% probability, but it already drops the chance that the SI joint is causing your pain significantly, all right? And so if you do have back pain, then it could be disc, it could be facet, it could be something else, all right? Let's just say, no, I don't have back pain, Charlie. Maybe you have pain that is not necessarily in the back, but somewhere in the butt and goes all the way down the leg. So do you have buttock and leg pain, numbness and tingling that extends below the level of the knee, possibly even into the foot? If yes, the SI joint is not the likely source of your pain. How do we know that? Because again, studies show the chance of SI joint problem referring below the level of the knee into the foot and causing nerve type symptoms, numbness and tingling at that is very low. All right. So again, you can essentially rule that out right away. And then what you can do is you can say, hey, is the neurological exam 100% normal? Do you go through the straight leg raise test and it's perfectly fine? Are you able to go up on your right toe, right? Calf raise right, calf raise left? Are you able to walk on your heels? Do things feel even relatively as far as the sensation side to side? If so, and you're like, hey, they feel normal, right? Then it could be something else, all right? If it's not normal, then it confirms the symptoms you're experiencing from the back all the way down the leg, right, are probably due to nerve irritation or a sciatica issue, all right? Now let's just say you're like, no, Charlie, I don't have pain in my back. And I don't have pain below level knee in the foot, right? Then you must, just by deductive reasoning, have pain somewhere between here, somewhere between there, right? Not your lower back, kind of the buttock, and pain that does not go below the level of the knee. So it stays somewhere between your butt and the back of your knee. So you have buttock pain with or without radiation down the leg that does not extend below the level of the knee, all right? If that's you, which probably is, if you got to this point, then are centralization or peripheralization phenomenon observed? So does a repeated movement exam, which we reviewed in depth during this video, does a repeated movement exam change the location of your pain? If yes, again, SI joint is not the likely source of your pain. We know that centralization is highly specific and or diagnostic for a disc problem. Disc is the most likely source of your symptoms. Let's just say, Charlie, I went through all those different motions. And I mean, some hurt, some felt a little bit better, but like my pain's still right there in my butt. There was no centralization or peripheralization. Then are both SI joint pain provocation tests, the self SI joint pain provocation test of the thigh thrusts, the one where you're kind of laying there 90 degrees and you're pushing through, and that single leg bridge, are those positive? Do they provoke your familiar pain? If no, then the SI joint is not the likely source of your pain, and maybe you have something else. Maybe you have some other cause of buttock pain, piriformis syndrome, HHT, high hamstring tendinopathy, or something else, all right? If yes, if you've gotten to this point, then SI joint is the most likely source of your pain, and you can determine that with a high probability from the comfort of your own home. A DIY diagnostic test, again, which is going to be more accurate than that which you're going to receive probably somewhere else, all right? So again, if you work through this, I'll do this just so you can see it. You can rule things out. Rule out the SI joint. Figuring out if you have an SI joint problem is just as much about figuring out that you don't or confirming you don't have it as it is. Cool. So hopefully that is helpful. Bottom and top, again, very algorithmic way of working through a flowchart to determine the most likely source of your symptoms. All right. All right, so hopefully that was helpful and clarified everything for you. Again, you can always go back, review this, slow me down, watch it as much as you need to, such that you can get clarity. And just remember, though, at the end of the day, don't take this too seriously, all right? It is a very algorithmic and scientific and validated by the research as a way to identify with a high probability the SI joint is the source of your symptoms, as well as some other things as you've seen in there. But, you know, diagnostics, again, are not perfect. They're not 100% black and white, but rather exist in probability. So you're just going for the most likely source of your symptoms by working through these things. So again, don't waste too much time or energy / money, right? Searching for that 100%. It's definitely this with no question, all right? Because again, diagnostics is more about ruling things out than ruling things in. Deductively, that's how we got to that most likely source being SI joint. We rule out disc, we rule out nerve, we rule out some other things, and then boom, this is it, all right? We use negation logic. By understanding what something isn't, you can learn what something is. Again, we can call this diagnosis by subtraction, or you can diagnose by subtraction. And this is really the art of the medicine, right? If you are interested in sort of getting access to my entire diagnostic flowchart, including one similar to the one that you just saw, as well as everything else, to kind of zoom out and see things even in a bigger picture, all right? So we talked about SI joint, a little bit about disc, facet, whatever, but if you want to include hip joint problems and piriformis syndrome and high hamstring problems and the mind and all these different things, be sure to check out. There's a link here where you can download my DIY diagnostic guide for free. It'll help you out a ton. Where we go through top to bottom, figure out the most likely source of your symptoms, okay? And again, I want to highlight this, right? So Charlie, you share with me how to evaluate systematically to tell if SI joint is the problem or not, but what do I do about it? So the problem with diagnostics is, again, they don't tell you what started it. hey, this is going on, but it doesn't necessarily tell you what to do about it, why it began, or how to prevent it. So how do you treat it? Well, you've got options. You've only got so many options. People are like, well, what do I do? There's so much. There's not really. Bucket things, synthesize things, all right? You've got pills. You want pills. You've got shots, right? You can get shots. You can get an SI joint injection if you want, right? But just like numbing your face when you get a procedure done there, it's probably going to wear off, right? And then you can have surgery. You can try to fuse the thing, right? But as you've seen, if you fuse the spine, often causes SI joint problems because the spine is meant to move and the body's meant to move. If you lock something up, it's going to cause problems elsewhere. If you lock up the SI joint, it could cause other issues. There's really not really strong and or obviously guaranteed outcomes with any of these things. And so you'll see what I'm a proponent for in a moment. So you've got pills, shots, or surgery, or you've got movement in the mind as medicine. There's really nothing else, all right? All possible treatments you can come up with, acupuncture, this, that, they all fall into one of these buckets. And so you have to ask yourself, what do you want, right? You can either go to someone, rely on them to move you and do the thinking for you, which if you ask me, just creates dependency, right? But this is what you're going to get. You've got this SI joint dysfunction, this upslip, this downslip. They're going to be back there checking out your hiney boodle, right? Oh, this pelvis is this. No, your hips. And you're doing all these tests. Twisted pelvis. You've got these muscle adhesions, these subluxations, inflares, outflares. I'm sure there's other terms that aren't even on here, right? You've got loose ligaments, whatever that means, leg length problems. But none of this stuff is valuable in that it's not valid and or predictive of SI joint issues or pain. And it's not reliable. In order for something to be useful, we all have to agree upon it. And if one person cannot agree, the chiropractor A and chiropractor B cannot agree upon the location of things because we have no standard normative reference for what is, good position or bad position or right or wrong or whatever, we cannot identify these things. And so look, if you are lost and confused, chances are you might want to rely on someone else to tell you, right, and give you comfort in knowing that you've got this upslip, you've got this downslip, you've got your hip doing this or hip doing that. But just know that it's not based off of science. It's totally fabricated and based in theory. And if you're okay operating off of theory and guessing and feeling like, well, I'm just going to trust, but in the back of your head, hey, they really probably don't know what they're doing. If that's what you want, then keep doing that. Or what I would say, best option is because you're the only one who feels your pain and who best understands it, then perhaps you're the best person to resolve it. This is why I'm so passionate about teaching people like you in pain how to solve their own problem. You feel something I don't. Therefore, you are in a relative position of power. Why do I say relative? Because you don't know what I know. But as soon as I start to give you what I know, then guess what? You're going to be in a way better position to solve this now and in the future. So with the right tools, resources, knowledge, and support, most people, including you, can learn to heal themselves. You can do it. All right. And the process, regardless of whether it's SI joint, disc, or that, is the same. I call this the 4-step pain relief process. You first need to optimize things mentally and physically. There are probably things you do not know, you don't know. Things you don't know yet, right? That you're doing, habits, routines, right? Ways of thinking, paradigms and or worldviews and or beliefs that you're holding that are keeping you back and continuing to aggravate the problem. You cannot manage what you do not measure. And so at the end of the day, you've got to learn to self-assess and objectify this. How are you going to tell what's working or what's not working? We have to teach you to self-assess. And you know how to self-assess better than I know how to self-assess because you actually feel you have a direct tie into the pain that you're experiencing. Then we can teach you to use the brain and the body as medicine. Right? If you're given a sheet of exercises and trying a bunch of random things, this is not a scientific way to solve a problem. Right? And so how can you tell immediately in the moment if you should do an exercise, if an exercise is a waste of time or something's going to make you worse? There is a process for figuring that out. All right. And then we need to get you back to life. We need to teach you a step-by-step formula for getting back to things such that you don't flare things up. And if things do flare up, you know exactly what it means and what to do now, again, and in the future to get you back to 100%. So this is a process and everyone goes through it. Optimize, self-assess, mind and movement, get back to life. And so look, if you are interested in learning a little bit more about how we help people and teach people all around the world with these back, butt, sciatica problems, how to fix themselves naturally using the power of the mind and movement as medicine and using a very scientific, as you've probably gotten a sense of today, then I would invite you to check out our free workshop, Beat Butt Pain Workshop, where we go through, again, some different things that you can begin using and or some ways that you can start to begin shifting your mindset around how you're approaching this, okay? And so check that out. It's completely free. A ton of value inside of that. All right, you can click probably above. I'll put a little link here as well as in the description if you'd like to check that out. All right, so that is all I got. Hopefully this was useful. Let me know your thoughts in the comments. Was this helpful? Was it not helpful? Was I able to take, right, all of this stuff, right, out there in the world, share with you, right, diagnostically what somebody like myself could do or would do, or what a top orthopedic diagnostician would do, and then boil it down in a way that makes sense to you. Was I able to do that? Did I do it effectively? Was it helpful to have that flow chart and see the logic and the way that I think through things? Let me know your thoughts in the comment. And then, as always, if this was useful, please share. And let other people know that there is a way, other than just getting painful injections and more x-rays and MRIs and things like that. There is a way clinically, using what you have, the pain that you're experiencing, and a systematic movement exam and process such that you can figure out the most likely source of your symptoms with the highest probability possible. Hopefully this is helpful and taught you how to evaluate the SI joint. Thanks.